Okay, good afternoon, everybody, and welcome to Fertility Talk Live. I'm sure we've got quite a few of you that has been tuning in, and it's a topic that a lot of people have been wanting to hear about and discuss. So today we have Professor Bouic. He is from Synexa, which is in Cape Town, and we are very excited to hear what he has to say, because I think it's a topic that we get a lot of. And we've got the miscarriage awareness or pregnancy loss awareness month that always comes up, and then all the stories come out. And I think the past year there's been quite a lot of talk about, and people more opening up about miscarriages. I myself, I've had 3 miscarriages, so I've been there, and that's, like I always say, it's only the 3 that I know about. And I'm sure there has been more, and especially when you're suffering from PCOS, it's one of the things you unfortunately deal with. So I'm just going to give you, I'm going to hand over to Professor, but before we do that, I actually want to see how many of you are live, and let's just see how many are live. So Professor, I'd just like to say thank you very much, first of all, for joining us here today. And it's a topic that we really need to discuss, and we can't wait to hear what you have to say about and what there is to offer, the help you have to offer the ladies. So please feel free to talk a bit more about where you're from and what is Synexa, what does Synexa do, and how can Synexa help the ladies?
Sure. Thanks very much, Leanne. So good afternoon, everybody. And so just very briefly, my name is Prof Bouic. Trained as an immunopathologist in Lyon in France at the University of Claude Bernard, returned here to South Africa and Cape Town in 1984, and I set up a diagnostic immunopathology lab at Tygerberg Hospital. I ran that lab for 22 years as HOD, and obviously immunology is my specialty. And in 2003, I decided to give up my full-time employment with the NHLS, and I formed my own laboratory where Synexa actually does a lot of clinical trial support. In other words, we help pharmaceutical companies in developing their drugs to show that it's safe, firstly, safety, as well as efficient. But part of the Synexa offering is also a specialized diagnostic laboratory where we do non-routine diagnostic work. In other words, we don't do the full blood counts, liver function tests that are normally offered by other pathology groups, more specialized immunology tests. And part of those tests are in fact looking at the immune profile and the microbiome of, especially the immune profile of women who are battling to maintain a pregnancy. In other words, recurrent miscarriages. And it's something which I was lucky enough for me to have my own children very easily, in fact. But the more I dealt with women who were looking for help, who were being referred from fertility clinics, the more I realized how huge the problem is out there.
Yeah.
And unfortunately, apart from the routine, ICSIs and IVF procedures, etc., and the frozen embryo transfers, there isn't much explanations provided.
Yeah.
And I think it's time for us to educate not only the public so that they know what is happening, but also to be clinicians so that the clinicians know what tests to ask for, when to stop just hammering at the same old routine protocol without taking a step to say there might be a problem here. And what I'll be talking about today is it's based on literature, it's based on published work. And what we do is we offer these services in Cape Town or in South Africa, obviously, because it's quite easy. But I do know that we often get requests from people living overseas, in Europe and UK, etc., where unfortunately we can't really provide the samples until further notice. And just watch the space. We are busy expanding our services into the US as well. So if I may, Leanne, let me just share my screen with can you maybe disable from your side so I can share my screen?
There we go. I've just activated it, so it should be fine now. Let me know if you are able to do that. There we go.
Okay, so let me just make that my full screen. Okay, I hope that everybody can see my screen. Can you see it, Leanne?
Yes, I can see it's perfect.
So the topic today is about recurrent miscarriages. And obviously, I just want to present to you what it is about the immunology of the endometrium that could possibly account for these chronic recurrent miscarriages. So, I mean, obviously, it is every woman's dream when they get married for them to have their own children. Yes, a pregnancy is in fact what we call a symbiosis between two different individuals. In other words, the fetus carries both the fingerprints of both the mother and the father. So it's okay as far as the immune system is concerned, in that it will not attack the fetus because it's blinded to the mother's own fingerprints. But the immune system has been trained to actually get rid of anything foreign. So because the fetus is in fact a half foreign body, it's almost a transplant, trying to implant into the endometrium, the aggressive cells of the endometrium will see the fetus and get rid of it. So the maternal immune system status is extremely, extremely important. She has to be in a state of tolerance, as in the little smiley face in the green, and that is if she's tolerant, she will implant and she will carry that pregnancy to full term. However, if her endometrium is aggressive, and I'll explain to you what I mean by aggressive, she will chronically reject that fetus and it gets translated or called a miscarriage.
Yeah.
So infertility, it's not really the right term that we should be using here. It's a lack of implantation. Infertility is when the male or the female have no gametes. In other words, the woman doesn't have any eggs or the male doesn't have any sperm. That is true infertility. But unexplained infertility or lack of implantation is what we are dealing with here. Very often we refer to these cases as SRAs, spontaneous recurrent aborters, either naturally. These out there who are battling obviously have recourse to your fertility specialist, so you know about the lack of implantation or the failures after IVFs or even frozen embryo transfers. There are quite a few factors involved, obviously hormonal, there might be physical factors. I'm not going to be talking about that. There are certain cases where the moment the septum is corrected, the woman falls pregnant. But here I'm talking about the immune factors which may lead to implantation failure. The way we do it is we request the woman to collect menstrual blood in order to profile the immune cells of the endometrium. Now, people might think, but why menstrual blood? Well, basically, menstrual blood represents the barrier of the endometrium or the lining of the endometrium, which has been prepped during the cycle. And because she has not fallen pregnant, she sloughs that off and she gets rid of it as far as menstruation is concerned. And we know that the menstrual blood is really the closest we will get to the real endometrial and uterine microenvironment, and it's not having to do a biopsy. The only other way would be for us to biopsy the endometrium to do this immune profile and obviously report back, but you can't do that. It's very invasive and you can't do it on a repeated basis either. So the easiest and the closest we can do is to work with menstrual blood. Why menstrual blood is because we are looking for 2, in fact 3 or 4 different immune cells. The first, I'm sure a lot of listeners out there have heard about NK cells. Everybody's talking about NK cells. Now, unfortunately, NK cells sounds extremely aggressive because the real word would be natural killer cells. Whereas to remember that in the endometrium, these cells are in fact baby friendly. They are the cells which induce implantation or allow implantation. In the peripheral blood, we have the cells which secrete factors which are extremely aggressive. Whereas in the endometrium, we have these cells down here, NKR1. Why are these important? Because these natural killer cells are directly under the influence of progesterone. And that is why during a pregnancy, your progesterone climbs, because the aim there is to increase the number of these NK cells so that they actually allow implantation. I always call them, they're forming a little barrier. They're putting out their arms around the fetus, closing in, getting more and more numerous in numbers, thereby creating an environment which prevents the aggressive cells from attacking that fetus. So this is the very, very first cell which the woman should have a decent level of. From some limited literature, it implies that when we do the profile of the menstrual blood, the woman must start off with, before implantation, at the time of pregnancy or fertilization, she needs to be close to 15%, because every 10 days, these cells double up in numbers, thereby obviously creating this environment, beneficial environment of implantation. So NK cells, I prefer to call them either UNKs for uterine or ENKs for endometrial NKs. It's not the same NK cell that we would see in the peripheral blood. In the peripheral blood, they are extremely, extremely aggressive. Why do we know these are important? Now, we all know what these menstrual cycles look like, the hormonal cycle. That is from day 1 up to about day 12, 13, the estrogen increases in levels, in plasma levels, and the aim there is for you to ovulate. Yeah. The ovulation takes place around about day 15, but from about day 15, that is when the progesterone starts climbing, and it reaches a peak around about day 22, 23. So this is from the fertile period to implantation. When it takes place here, progesterone actually exceeds the level of estrogen. Now, what's important to know is what is the effect of these two hormones on these so-called immune cells in the endometrium. And if you look down here, you'll notice the natural killer cells here from day 10 to 12, they're present, yes, or not too bad. From day 22, 23, they start increasing, and near the end of the cycle, these natural killer cells are in fact in excess of any other cell. Now, that is because they are directly under this influence of the progesterone in the blue line here, and that is the progesterone increases the numbers of cells in case she has fallen pregnant. Because if the woman has fallen pregnant, the progesterone doesn't drop, it goes even higher, and it's the progesterone which maintains that pregnancy. But indirectly, it is maintained by the presence of these so-called ENKs, endometrial NKs. So hormonal levels measurements is very important when you go onto this journey, because I'm finding, in fact, a lot of women don't have the surge of progesterone near the end of their cycles. So they should be helped. Yeah. The clinician should be suggesting the use of extra progesterone in order to improve this prognosis. Yeah. So these are the cells here, the UNKs or ENKs. They differentiate into cytokine-producing cells. Cytokines are soluble factors, and in this case, the ENK secretes factors which are immunosuppressive. So what they do is those factors immune suppress possible aggressive cells in the endometrial. So they just literally just chill those aggressive cells, thereby allowing the fetus to actually implant. What they do is they allow the invasion of the trophoblast, you know what a trophoblast is, into the decidua, and obviously promotes the vascular development of the fetus. And what's important is they change in numbers from very early pregnancy to mid-gestation, where they are the highest. And what's interesting is there's now 1 or 2 publications which appear, which implies that at the time of giving birth, near the end of the 9 months of pregnancy, the numbers decline. So in other words, they increase during the pregnancy to maintain the pregnancy, and as the pregnancy goes to full term, near 9 months, they start decreasing once again, and we think that in fact a birth could be almost seen as a rejection crisis. Suddenly there aren't enough of these cells at the end, and the woman rejects the baby, but obviously she's giving birth to a full-term fetus. There are also T cells. Now the T cells are present in most of our tissues, but it depends on what type of T cells. There are those which are very aggressive, namely the Th1, T helper 1, and there are those which are very, very conducive to pregnancy, and that is the Th2. And again, literature says that under the influence of progesterone, the T cells of the woman's the T cells in the woman's endometrium tend to be predominantly of these so-called baby-friendly Th2 phenotype. So we measure the presence of T cells in the menstrual blood as well. Very important, these cells, these Tregs or T regulatory cells, work hand in hand with those ENKs. So we have to have a profile where the woman presents with decent numbers of ENKs, decent numbers of these T regulatory cells, which are directly immunosuppressive, once again, and these two cell types counteract the aggression of the T cells and any other cells, especially viral triggered cells like NKTs. So just to put this in a simplistic way, if we have in the endometrium very strong T regulatory cell activity, which are immunosuppressive, they prevent those aggressive Th1 cells from taking over. And what happens, because this is a seesaw, it's a yin-yang, is that there's a state of tolerance induced, and the woman goes on to have a normal pregnancy. Whereas if she starts off with very aggressive Th1 cells, loads of them, not enough immune suppression, weak immunosuppression, in fact, the Th1 cells induce immunity. In other words, it allows the immune cells to react to the fetus, and it leads to other miscarriages, infertility, and even preeclampsia. So these cells have now become a new target where people are now saying, in the cases of miscarriages, can we artificially target these T regulatory cells in order to induce a natural pregnancy or to promote a pregnancy? So yes, we're going to see new drugs coming on shortly, where these drugs will be given to women who present with lack of tolerance, in other words, not enough T regulatory cells, not enough NK cells. And what we're going to do is we're going to shift that seesaw in the direction of promoting a pregnancy. Let me just touch on a parallel phenomenon which is also critical for a pregnancy to occur, and that is the microbiome. Now, we know that the mucosal surface from the mouth right through to anus, that mucosal surface is bathed with billions and billions of bacteria that we would refer to as the microbiome. So yes, the microbiome in the gut would be very different to the bacterial species we see in the vagina or the endometrium, but the role of the microbiome is identical in both cases. For instance, in the case of gut, when we have the person with these microbial populations being disturbed, we very often refer to these people as having IBS, Irritable Bowel Syndrome. What that is, it's in fact a chronic inflammatory condition in the gut. Okay? And until such time that we normalize these mucosal surface bacteria with the use of probiotics, okay, the woman or the person, in fact, doesn't have to be a woman, but the person battles with IBS. Now, in the endometrium, exactly the same phenomenon happens. In that, if the woman does not have decent levels of good, friendly bacteria, mainly of the lactobacilli, lacto in Latin means milk, so it's the group of bacteria that in the gut help us to digest milk proteins. In the endometrium and vagina, these lactobacilli change the pH and maintain decent pHs. But at the same time, they are there to trigger the immune cells below the surface of that mucosa. So what we're finding is that women with disturbed vaginal or endometrial microbiome also battle to fall pregnant and maintain pregnancy, because without enough of these microbial species, we have these very, very inflammatory cells, especially those cells which reject the fetus, being very active and rejecting that little embryo trying to implant. So basically, we need to reinstate the status of the commensal flora in the woman if that is disturbed. So it's not just looking at hormones, not just looking at physical problems. It's an immune phenomenon, and the microbiome directly impacts on the activity or what type of cells are present in that endometrium. If we don't have enough of these good friendly bacteria, the woman's inflammatory aggressive cells predominate and gets rid of that embryo.
Yeah.
It has to go hand in hand. And that is why now companies are now developing pessaries specifically to address this type of disturbance. And that is very easy. It's a vaginal swab. You look to see what microbial species are present. If they are disturbed, give the woman the treatment of the pessaries to use once a day, change that microbial flora, the diversity, get rid of the bad ones, and hopefully that translates into an immune reaction, making the woman baby friendly. So let me just give you some exact example of what the way we report it. This is an example of an endometrial sample, menstrual blood. These cells up here are the T cells. Here are the ENKs. We know that there should be around 15% to start off with in the red little box. You'll see in this case, the woman only had 3.75%. Now, I can't remember exactly the case behind this, but this person came to us because she was battling to implant. They get referred to us for this type of test because the IVF clinics or the fertility clinics, after 2-3 rounds, they say, well, we don't quite know. We had perfect embryos. We put them back, but you're not implanting. Let's look at this. Here's another case where outright this woman is immune aggressive. These cells down here are possibly the most aggressive of all immune cells. We very often see these cases of raised NKTs in cases of chronic viral etiology. In other words, women who've had previous HPV or pap smears abnormal, because of the HPV, it's triggered these aggressive cells. Or similarly, women who battle with herpes, these NKT aggressive cells would be predominant, and they are very aggressive. Now, this case here, it's a lot more difficult to manage that woman to make her baby friendly. You have to target these cells and to bring them down. But here's a case where when we profiled her, she was almost perfect. This was a preventative test requested by the person because they were considering starting a family. She had heard about our testing. And in fact, if you look here, she had decent levels of CD3 T cells, not too bad, should never be above 75%. NK should be close to 15%. She had 11%. These aggressive cells should never be more than 10%. She had acceptable levels of T regulatory cells. Well, guess what? This woman had a totally natural pregnancy. So there's a direct correlation between the features of aggression versus the features of immune tolerance, baby-friendly type of environment. Okay. Yeah. Now, I want to make one point clear. When the women have themselves tested, if this profile is not normal, there are ways and means of reversing that. So it's a reversible process with certain meds that need to be used, okay? And it normally takes 2 to 3 months, but get the profile as close as possible to normal before going back for more and more rounds of IVFs and transfers. Because as long as this profile is not normal, it will not succeed. Yeah. And I'm not talking about the cost involved here, folks.
Yeah.
The emotional cost has not been costed. I would hate to be in the shoes of some of these couples who keep hammering at it after 8, 9 IVFs and AIs, failures. The emotional roller coaster for that couple is, you can't put a price to that.
Yeah.
So it's a yin yang, folks, okay? We have to have immune aggressive cells because those are the cells which protect us against viruses and bacteria. But at the same time, we have to have a certain level of good, baby-friendly, immune suppressive cells. And these would be the cells that fall into this quadrant here, so-called immune regulatory cells. And they would be working in yin-yang against the inflammatory ones, the aggressive ones. So we don't have all the answers yet. But what we do know is there are two components which directly impact on possibility of success and good prognosis outcomes. First is vaginal microbiome, definitely. Secondly, the endometrial immune profile. In other words, do you have the right baby-friendly cells at the right levels for you to implant? And infertility management, I hate to use the word infertility because it's not an infertility issue here. It's an implantation failure.
Yeah.
So there's a cost to that. And as I mentioned just now, the emotional cost has not been, there's no price to that.
Yeah.
We have to be a bit more open and accept that the fertility specialists may not have all the answers. So ask questions, go onto the blogs, go onto the support groups, get more information. The more informed you are, the better equipped you people would be.
Yeah.
And I want to make one thing clear. We very, very often overlook the male.
Yeah.
Often I deal with couples where the male profile is not good. It really is not conducive to a good pregnancy. But the fertility specialists in some of these clinics overlook that. They tend to say, oh, it's good enough for me to work with. It's not good enough for the patient. It's not good enough for the couples. You have to make sure that both sides are looking good so that the prognosis of the procedure is greatly, greatly improved.
Yeah.
So thank you. Thank you for the opportunity to share with you some of our services that we provide. And as I say, I'm very open to even telephonic consults, email consults, not a problem. I'm very open to providing support, education, any advice. I'm really, really, really very, very happy to do that for anybody out there who are battling. There's nothing more rewarding for me when I've helped a couple that I get that email to say, guess what, we're pregnant. Or I get that with a photograph of the baby to say he or she was born 2 days ago. That is my payment. That is what I'm good at doing, and that is the payment I receive in return. So thank you so much.
Okay. I can't thank you enough, Professor. That is so informative. We don't have enough education regarding or being told like this is what you can do, this is your next step. So you go and you fall pregnant constantly, because like I said, after three miscarriages, nobody has been able to tell me why I miscarried. They will say, oh, it's PCOS, but nobody has actually told me this is the reason why. This is a problem. I'm always saying, I know for a fact it must have been more pregnancies, but nobody has said to me, I go for the IUI treatment or whatever treatment I go for all the medication, but at the end of the day, I can't carry the baby to term. And I think this is definitely what is missing and what our women need. So yeah. I thank you so much for this. We definitely have talks on this. So ladies, there you have it, because we're always having the awareness about miscarriage awareness or baby loss awareness, but it's never of this is our next step. This is what you can do to help. This is where you can go. So Synexa is based in Montague Gardens. Am I correct?
Yes,
I've actually been to your office years ago. I think when I told you about it years ago, I was at your office, and it was very in my early stages of everything, and I never actually went through it. And I so wish I actually went through with it at the time.
Never too late, Leanne. Never too late.
40.
My darling, my mother had a natural child at 53.
So wow, ladies. There you heard it. So it's not too late. So those of you who are 40, 41, 42, it's never too late to give up. I'm always promoting don't give up.
Totally.
Yeah. So exciting stuff, and it's great to hear these things. So ladies, just want to thank Professor. I wanted to see if there's any questions. If we have, I'm sure there must be questions. And always as soon as we end the talk and the questions come in, or I get the inboxes and stuff. So what I'm going to do is
what you can do, if you do get questions, bounce them through to me and I can answer you back to you. So it can remain anonymous and all the rest of it, no problems, but any relevant,
perfect.
As I said, the more questions asked, the better equipped everybody is.
That's perfect. So the professor said that if you guys have any questions, please email it to us. You can email it to me directly. I will forward it to the professor and he can respond. And if you are based in Cape Town, and I'm sure if you are based in Gauteng, Durban, wherever you are, Limpopo, I'm sure we will assist you or make some way to assist you. Please get in contact. Yeah, this is something that a lot of women, especially when you're dealing with PCOS, this is something that happens. It's one of the things that happens. So please can contact us. Thank you again, Professor, for taking the time out to be with us. We are going to do another Instagram at one evening. I think there we're going to have quite a big audience as well. So thank you and have a great afternoon. Thank you.
Thank you so much for the opportunity. And let me know what I can do further to help, okay?
Pleasure. Thank you very much, Professor. Bye.
Bye, everybody. Thank you. Bye-bye.